I'm fine with the lights off if you guys don't fall asleep. Try not to fall asleep. I'll stay lively for you guys today. Okay, we're going to do lectures 3 and 4 today. So 3 hopefully in this first hour, 4 in the second hour. Cover lids, lacrimal disorders, diseases, and then conjunctival diseases. Before I forget, I don't see you guys at all tomorrow, but I do see you on Wednesday a lot. So you've got your lab at 8. There is a PowerPoint in Canvas that's the Morgan Lens PowerPoint. If we have time at the end today, I'll run through that real quick, just kind of giving you a expectation of what's to come. But there's also a map of where you're going to have the lab if you're not familiar with Metziland. And again, there are going to be a lot of AIT soldiers there. I always just say, don't even look at them. Don't associate with them at all, because they're not your friends, and they can only make life terrible for you. I know. I teach them every day. Okay, let's hop in here. Turn the clicker on. There we go. Okay, so lids, lacrimal disorders. You can see there's several areas here that are bolded, but these are all pretty. I think they're simple diseases and disorders. We'll talk about the important ones and things that I want you guys to take note of for your, not just for the pants, but more importantly for when you're actually practicing as a PA. So you guys are going to be able to treat a lot of these disorders on your own. They're pretty common. Long list, but it's pretty manageable. Okay, this is just a review slide. Some of the anatomical landmarks. We won't really go into that because we covered that in the first lecture. For the first 2 diseases I want to talk to you about are lid malposition diseases, okay? So the first one is ectropion, and the second is entropion. Now these are pretty easy to remember because ec means out and en means in. As long as you remember tropion is lid malposition, then ectropion is an outward turning of the lid, and entropion is an inward turning of the lid. Okay, take note that while these are 2 different conditions, they do have a lot of very similar signs and symptoms when they present, when the patient presents. So anytime you have a lid disorder, you're going to have eye irritation, you'll have burning of the eyes, foreign body sensation, potentially some tearing. Okay, and the way you get those is different for both conditions. So let's go into ectropion and kind of how do we get these diseases. Ectropion is the outward turning of the eyelids. Okay, so a lot of times this is on older patients. Okay, as you age, things sag a little bit. You lose that elasticity of the skin, and the lid will just, the lower lid typically just starts to droop away from the face or from the eye. Okay, that's usually the most common. Sometimes you can get some scarring on the lower lid if you have like a lid laceration and it scars poorly and doesn't heal properly. You can get some scarring, maybe some paralysis if you have like a Bell's palsy. Side note, one of my students that just graduated got Bell's palsy right in the middle of class. If you haven't seen Bell's palsy, it looks like the patient's kind of having a stroke because half their face doesn't work. So she was kind of talking about the side of her mouth and she couldn't close her eye. We actually deal with Bell's palsy quite a bit because the dry eye nature of it, you can't close your eyes and the cornea is constantly exposed. We'll talk more about that in the corneal lecture, but that was just a fun, well, it was an interesting aside, definitely not fun for her. Then entropion, okay, so again, ectropion is an outward turning, entropion is an inward turning of the lid. A lot of times entropion will either be, either a child is born with a lid malposition, or more commonly is from scarring and from trachoma. Okay, so you'll get trachoma in the eye, and it will cause that lower lid, the palpebral conjunctiva on that lower lid to turn in as that scar tissue pulls the lid in. And then how we treat it, surgical treatment is how we do it. Okay? So this is a picture of ectropy, and you can see these patients are older, right? Things are sagging on that patient there, and that lower lid is no exception. You can see the upper left-hand picture there, that lid is clearly turned away. The palpebral conj is exposed. It's pretty red, irritated. Okay. And then entropion, you can see here, the lower lids there are turned inwards. You can't even see the lashes on some of those. On that upper left-hand picture there, take a look at that eye. What do we notice about that eye? Yeah, those are all corneal sutures. So this patient with entropion, rather, likely scarred their cornea from every time they blink, those eyelashes are rubbing up against the cornea, causing massive amounts of irritation. And it'll end up scarring the cornea after a while. It's kind of like having sandpaper on your blinks, which obviously isn't ideal. So that patient had a corneal transplant, likely from the entropion. And unless they fix that lower lid, they're probably going to have another corneal transplant. I don't know why they didn't fix the entropion first, but again, I'm an optometrist, not a surgeon. So let's get some bonus points here. The right side picture, what's wrong with that eyeball besides the entropion? That is a gnarly looking cataract, yeah. So that patient's visual acuity is terrible because that cataract is pretty opaque there. All right, any questions on entropion versus ectropion? Surgical treatment, ectropion outward turning, entropion inward turning. Signs and symptoms are pretty similar for both. Okay, next we have lag ophthalmos. Lag ophthalmos simply means the inability to close the eyelids. So if you can't blink completely and make the eyelids touch one another, then we term that as having lag ophthalmos. Okay, similar signs and symptoms to entropion and ectropion. Anytime you're not able to close that eye completely, you're going to have irritation, burning, foreign body sensation, and tearing. Why does it tear if you can't close the eye? You don't really have anything in the eye. Why are we tearing? With your chest. Yeah, so, yes. The lids, you recall, act as kind of a squeegee to spread that tear film around. And if you don't have the lids acting as that squeegee, then the brain is going to constantly get a signal from the cornea that it's dry. And it's going to trigger the lacrimal gland to pump tears onto that eye. And those tears are pretty poor quality tears, and they're just going to stream down the patient's face. So that's why tearing is a symptom of lag ophthalmos. Okay? Signs are pretty obvious, right? If you ask a patient to close their eyes and they don't close, then they have lag ophthalmos. Okay? Pretty easy to see that. Okay, again, there's several ways you can get lag ophthalmos, and ectropion is a way to have lag ophthalmos, right? If that lower lid isn't able to completely touch the upper lid because it's too lax. Bell's palsy can obviously cause a lag ophthalmos because your facial nerve's not working. Again, we said the facial nerve controls what muscle that closes the eyelid? 007, orbicularis oculi, very good. Proptosis, what is that? Proptosis is what happens when the eyeball is protruding out of the eye. So if that eyeball gets pressed forward for whatever reason and starts to protrude out of the eye, we call that proptosis. Okay. So if we have proptosis and that eyeball is being pressed forward, then the lids aren't necessarily long enough to close over that eye. Okay. We have to get that eyeball back into place in order for the lids to close. Question?
What's the difference between exophthalmos and proptosis?
Nothing. Those are synonymous terms. Yeah. Nice work. Where'd you see exophthalmos? Good work. Yeah, very good. Okay. Anyone in here wants to get a facelift or a lid lift? Hopefully not yet. But when you are of that age, like in your late 50s, early 60s, and you want to take several years off your face, go get a plastics consult and talk to an oculoplastics doc. Okay? A plastic surgeon that only specializes in the area around the eyes. See if you're a candidate for a lid lift or a blepharoplasty. I've seen many blepharoplasties, and they literally take 15 years off of a patient's face. It's pretty awesome. Okay. However, if you don't go to an oculoplastics doc and you just go to a general plastic surgeon or a general ophthalmologist, they may take too much skin. Okay? That's a bad thing. If they take too much skin, that's going to cause the inability of the eyelids to close because it's too tight and there's not enough lid to close. So, side note, make sure you have an oculoplastics doc doing your blepharoplasties when you're needing a blepharoplasty. Okay. All right. How do we treat leg ophthalmos? Not a great way to treat leg ophthalmos because once that tissue's gone, especially if it's from too much being removed, you can't put that tissue back. So usually we're just trying to manage the patient's dry eye and hope that if it's like a Bell's palsy, that the steroids calm everything down in there. Or if it's some scar, maybe they can do a surgery to revise that scar, hopefully to get those lids to close. But a lot of times, again, we're just treating the dry eye symptoms. So we're making sure that lid stays, the cornea stays hydrated. Okay, so using a lot of artificial tears, gels, ointments. We can take the lid shut at night. That is not enjoyable for patients, especially if you're prone to like nightmares and you're trying to wake up and your lids are taped shut. So patients don't like to do that a lot. There's moisture chamber goggles that you can use that you wear, like they're almost like swim goggles that you can put on and wear at night. Those are also pretty uncomfortable, but they help. And patients with severe dry eye wear them because they would rather deal with the uncomfort from that than the dryness itself. You can do on like severe leg ophthalmos, they can do a tarsorrhaphy. So ophthalmology will kind of suture down the eyelids. This isn't super cosmetically pleasing because it looks like half of your eye is sutured shut, but it does help the patients to kind of close that eye. A lot of the tarsorrhaphies are going to be temporary anyway, so they'll go in, sew it down to try and have the body grow more skin cells, and then remove those sutures, and hopefully the lid will close there. You can also insert gold weights into the upper lid. I've seen one patient that's had that. It was not super successful. She still had leg ophthalmos pretty bad and couldn't close the eyes, but she had a much more valuable upper eyelid after. Okay, picture of Bell's palsy here. You see this patient can't close their eye, leg ophthalmos. The student that I had, she had no facial nerve on the ones. It was not working at all. She could not blink at all. It was pretty crazy. All right, ptosis. We've talked about that already. Ptosis is a drooping of the upper lid. Okay, please don't ever call it ptosis, especially to an optometrist or ophthalmologist. We will probably laugh at you. Ptosis is a drooping of the upper eyelid. Okay, you can get these again if you have a nerve palsy. What nerve palsy would cause a ptosis? 3. Yeah, very good. 7th closes. Yeah. 3 is the levator. Okay, so if the levator is not firing, you're gonna have a ptosis. You can also have a ptosis if you have Horner syndrome. Horner syndrome, you'll get a little ptosis that's damage to the sympathetic nervous system. We'll talk about that more at some point. I forget which lecture that's in. Okay. Now you can tell a patient has a ptosis. Obviously this one's pretty obvious. But if you have a patient in your exam chair and they're maybe complaining about it, or if you just notice something's not right when you're doing the Hirschberg reflexes, and you have that central pinpoint the light source in the center of the pupils. You can actually measure the distance from that light reflex to the top of the upper lid, and if it's off by more than 1 millimeter, the patient has a ptosis in that eye. Okay. You can get ptosis a lot of ways. Again, oh look, Horner syndrome. Third nerve palsy, we're going to talk about that. Myasthenia gravis, we'll talk about a little bit. Muscle weakness is myasthenia gravis, okay? So towards the end of the day, a patient may have myasthenia gravis and their muscles just become fatigued and the levator doesn't want to work, and so they'll develop a ptosis throughout the day. Okay. How do we treat ptosis? Usually that's a surgical treatment. If it's not a nerve palsy, okay, if it's a nerve palsy, then we get the nerve healthy again, hopefully. So it's like compression on the third nerve. Hopefully we'll remove the mass that's causing the compression, and then everything will work like it should again. But if it is some sort of congenital or scar that's causing the ptosis, they'll need to do upper lid blepharoplasty to change it out or tighten it up. Not too much though, because then you'll cause leg ophthalmos. Hey, here's a picture of congenital ptosis. Hey, we want to get this fixed in this kid. Again, this is pretty obvious, right? Pretty obvious that kid's got a ptosis. You can't even see the light reflex in that patient's left eye there. Why do we want to get that treated? Yes, and what's the condition we're trying to prevent? Amblyopia, yes, good. That would be an example of something that could cause deprivation amblyopia. Very good. Okay, another congenital ptosis here. You can really see the difference. Probably 1 millimeter in that patient's right eye there, and maybe about 4 millimeters in the left eye. Okay, we call that the marginal reflex distance, MRD, MRD1. Okay, MRD1 is the distance from the light reflex to the upper lid. MRD2 is the distance from the light reflex to the lower lid, and MRD3 is the total distance. Don't write that down. That's not on your test, nor is it important, but just for your reference. Marginal reflex distance. Okay, next we're going to talk about blepharitis. Bleph is a prefix for the lids and lashes. Okay, and itis is an inflammation. So blepharitis is an inflammation of the lashes and lid margins. Okay, does that look like a clean lid margin? Not at all. That's pretty gross. Okay. Again, on Wednesday, when I'm looking at your eyes, don't let them look like this, okay? Or you'll get a consult. Just like many of the other conditions, very similar symptoms, irritation. Anytime you have irritation on the lids or lashes, there's probably going to be corneal irritation as well. Maybe a burning, foreign body sensation, tearing. Okay? All these are very similar signs and symptoms for these conditions. So when you're trying to study for a test that you're going to have on like the 8th, I think, on these lid things, if everything's the same as far as signs and symptoms, you're going to have to figure out what else differentiates the condition to figure out what is actually wrong with the patient. Right? So don't just study the same signs and symptoms because they all have these same signs and symptoms. Okay. All right. Let's go back to this picture here. Yeah. So these crusty margins right here that you can see kind of coming out like a cone shape around the lash itself, that is poop. Okay? There's a mite called Demodex that will burrow its way into your eyelids and along the lash margin, and it will gorge on all of the deliciousness inside of there, and then excrete itself along the lid margins. And those cones around the lashes is that waste product from Demodex. So we'll oftentimes prescribe lid wipes that have like a tea tree oil in there, and that kills those mites off. And then if they're not there, then the poop's not there either. So yeah, blepharitis, you'll have like, it's almost like dandruff, kind of, like flaky, crustiness around the lashes that you'll be able to see very well under the slit lamp, okay? This is a picture of the meibomian glands, those bumps that you see on the lids. Okay, the meibomian glands are in the upper and the lower eyelids. We talked about these already. These are the glands that secrete oil, the oily outer layer of the tear film. And those glands are all capped, okay? So the oil is not able to secrete out, and that will cause that irritation and inflammation around the eye. And it also is part of dry eye syndrome as well. Okay, how do you get blepharitis? Usually you don't have the best hygiene. That's usually the case. Sometimes you will have good hygiene. You just have like dandruff or unfortunate other skin disorders. And no matter how well you're cleaning, you're still going to get crusting and flaking. Another way you can get it is like a staph overpopulation. So there's a natural flora around the eyelids that's staphylococci. And they're always sitting at a certain level, usually pretty low, but that's part of the natural flora of the eye. If, for whatever reason, your body's immune system can't handle that staph and they go crazy, then you'll get blepharitis as well. And Demodex, I mentioned, that's that little gross mite. All right, how do we treat it? Usually it's just getting rid of all the crud on the eye. Okay, so lid scrubs. You can use baby shampoo. That's kind of controversial, but it's cheap and works pretty well. So when patients have blepharitis, I'll have them put a little dab of baby shampoo in the palm of their hand, kind of work it into the lather, and then just scrub around the lashes, just like you're washing your hair, but you're washing the eyelashes, getting a lot of that crap off. You can use warm compresses. We'll talk more about warm compresses in the dry eye portion. For real bad staph, we can give erythromycin ointment. This is one of the only times that erythromycin ointment is actually going to be useful. Most of the time, it'll get prescribed for either eye infections or internal things, and it doesn't work at all as an antibiotic. It's pretty weak, the erythromycin ointment is in terms of antibiotic capabilities. But this is one of the areas where it actually is kind of useful. It also provides a secondary benefit in that it's an ointment, so that ointment stays on the cornea a little bit longer and provides comfort for the patient and their eyes. So sometimes if a patient has dry eye and we don't have regular artificial tear ointment, we'll just prescribe erythromycin ointment because it's not really going to hurt, and the ointment is a big benefit for those dry eye patients. You can also prescribe Doxy. I don't prescribe Doxy. There are some people that swear by it. I'm not a huge fan of Doxy for blepharitis because it usually just causes more GI issues for the patient than anything, and it doesn't really help with the blepharitis. So there's that. Okay, more blepharitis pictures. That one's pretty gross. Here's a picture of those Demodex mites. Those little things will burrow in. Not fun. Okay. All right. More gross pictures. Moving on. We are talking about a hordeolum. Okay, so next to hordeolum, please write hordeolum equals hurts. A hordeolum hurts. Hordeolum hurts. Okay. If you can remember that a hordeolum hurts, that will aid you in life when you're treating patients with a bump on the eye. Okay, so a hordeolum is an acute, painful bump on the eyelid. Acute, painful bump. Hordeolum hurts. Okay? So a patient's gonna say, I woke up with this bump on my lid and it hurts. Okay? Really don't even need to see the patient. Probably still should. But it's a hordeolum. Okay? Period, dot, end of sentence. That is a hordeolum. Okay? A lot of times you'll get a hordeolum because the meibomian glands have gotten clogged up And before they clogged, staph bacteria got inside of the meibomian glands and then replicated and started to fester in there, causing the bump. Okay? And anytime you have an active infection, there's going to be pain. So an acute painful bump, hordeolum, it hurts. How do we treat hordeolums? You can use a dry warm compress to try to open up those meibomian glands, to pop that pimple, for lack of a better term, out of the meibomian gland. Okay, that's pretty painful if you're pushing on a bump that already hurts and trying to squeeze it out like a big cyst. Any Dr. Pimple Popper fans in here? You don't really pop those. You need to typically surgically excise those. You don't surgically excise a hordeolum. Rather, first line treatment that I do is augmentin, which may sound like overkill, but I would much rather murder that hordeolum than let it fester into something worse. And it can fester into something worse. Okay? So we try, especially downrange, to aggressively treat hordeolums with an antibiotic. It says topical antibiotic here. You should just take that, put a big X through that. Don't prescribe erythromycin ointment for a hordeolum, because that's not going to touch it at all. Okay. You need some oral antibiotic. It says Doxy on the screen. Again, I don't like to use Doxy. Side note for the test while I'm thinking about it. You don't need to know dosages. You should know if you have a bacterial condition that you should treat it with an antibiotic. If you have a viral condition, treat it with an antiviral, fungal, antifungal. Okay. You should know like the main. Have you had farm yet?
Yes.
You should know like the main popular antibiotics, antifungals, oral, topical. Okay. Again, you guys should never prescribe a topical steroid. So when you see that, probably not the right answer. And other than that, just follow the slides, except for when I tell you to cross stuff off on the slides. All right, this is a bad bump. That one's pretty obvious. The patient has something wrong there. There's a big old bump on that eye. It hurts. This one's less obvious, okay? But you can still see there's a little bit of bump. There's some redness on that upper lid there. Hordeolum's right here. You can see it kind of popping down just a little bit. Okay, if we flip this upper lid up, the patient would be in a lot of pain, but you'd have a much better view of that hordeolum. Okay, this patient's going to get oral antibiotics. All right. So what happens if you don't give a patient oral antibiotics to treat their hordeolum? One of two things can happen. One of three things, I guess. Your body's natural immune system could take over and just kill it off. That's unlikely, but possible. What could happen, though, is the body's immune system still takes over and kills the bacterial infection, but it doesn't get all of the crap out of the eye, in which case you have what's called a chalazion occur. Okay? So chalazion is also a bump on the eyelid, but it's not painful anymore. It's just a hard bump on the eyelid. Okay? A painless bump is a chalazion. It's chronic. Okay? Underline the CH in chalazion and the CH in chronic. Chalazion is chronic. Right? This one's pretty obvious. This lady, female, I'm guessing, has a bump on the lower lid there. Okay, that is pretty obvious, but it's not painful. Okay, you can press it, it's not going to hurt. Might feel a little weird that you're pressing the bump, but it's not going to be painful like a hordeolum is. Okay, so what? Let's see. Anything else? Yeah. So usually, again, chalazion is going to occur after you have a hordeolum that doesn't get all the crud out. Okay? Hordeolums can turn into chalazion. How do we treat it? The military treatment system wants patients to use a warm compress and then try to squeeze that crap out first. And after that doesn't work, which it's not going to work for 99% of patients, but after they try that for a month, then ophthalmology will go in and surgically remove the stuff in there. They'll do what's called an incision and curettage, so they'll make like a little incision on that bump, and then they'll go in with like a little mini ice cream scoop and mix everything up and scoop it all out and get the little sac out of there too, and then suture it up. Okay. So warm compress first, then surgery. You don't have to treat a chalazion either. Okay, if it's not bothering the patient cosmetically or causing them any discomfort, you don't have to treat a chalazion. It usually bothers patients cosmetically, and they'll get it removed. Like this one's going to probably bother that patient. That's a big bump. Okay, this one's less big. Maybe it doesn't bother the patient. Here's a video if you want to see how they incise and curettage those. Another bump. Okay. All right, blazing right through. That's it for lid disorders. Okay. Fairly simple, a lot of slides, most of our pictures. Okay? Try to remember the big points that we hammered home. When we review for your test, I have 2 review lectures posted. They are ridiculously long. I used to go through both of those lectures in class. I don't anymore because, number one, it is absolutely exhausting trying to get through 300 slides in 2 hours. Number 2, I don't think you guys retain a lot of stuff when I'm powering through 300 slides in 2 hours. So what I have done now is I just print out the blueprint and I'll go through your test and I'll see what things are on your test. And then I review those things. Okay? I write your test based on the blueprint. Okay? It's obviously important that you guys understand what's on the advanced blueprint, or I'm not doing my job. And then I also fill in things that are important to you from a military standpoint, operationally. Okay, so we'll cover like trauma. That's not on your advanced blueprint really, but or it's a tiny section, and we expanded a little bit for military healthcare, and then triaging ocular emergencies as well. So you'll be well covered. I've done that for the last 2 classes, review-wise, and it's been pretty well received and successful, so fear not. You'll be all right. Okay, moving on to lacrimal conditions. We have 4, I think, listed on the blueprint, okay? So the first one is dacryocystitis. Now you can break all of these terms down, okay? So dacryo means lacrimal in Latin or whatever. Dacryo is lacrimal. Cyst means sac. Itis is an inflammation or an infection. Okay, so if you break that word down, you already know what it is. Dacryocystitis is an inflammation of the lacrimal sac. Can you recall that the lacrimal sac is here? Okay, nasally, inferior nasally. Okay, that looks pretty gross. Okay. You can see that there's some swelling inferior nasally that's actually spreading to the superior nasal portion. Some gross mucopurulent discharge there, and a lot of swelling around. But that bump right here is the lacrimal sac that is infected and thus inflamed. Okay? So if you have a patient that's presenting with pain, inferior nasal area, that is probably dacryocystitis. Typically, this is bacterial in nature. Again, all that staph bacteria around the eye is fine, usually, until it's not. You get some of that staph going down the punctum, canaliculi, into the lacrimal sac. Sometimes it'll stay in the lacrimal sac and not drain out, and it'll fester in there, and that's when you get a dacryocystitis. How do we treat it? Augmentin. Okay. A lot of times, it would be somewhat confusing if I do a topical or an oral medication. If the condition is below the skin, you're going to use an oral medication, because topical isn't going to bust through that skin. If the condition's like right on the cornea or right on the conjunctiva, and a drop's going to touch where it needs to treat, then you use a topical, okay? But for this, probably not going to be using topical drops. You could to like try to help, but it's not really going to touch the lacrimal sac, okay? So oral augmentin would be the thing to use here. Not typically going to need surgery, okay? If it doesn't treat with the augmentin and perhaps there's a bump left over, ophthalmology will go back in and maybe clean it out and figure out what's going on in there. But typically, augmentin's gonna take care of this, no problem. Or Keflex or whatever oral antibiotic is on your formulary. Okay. All right. Don't confuse dacryocystitis with dacryoadenitis. Very similar. Okay, dacryo again is lacrimal. Itis is an inflammation, but now we have adin in the middle. Adin means gland. Okay? So dacryoadenitis is an inflammation of the lacrimal gland. And again, that is up here. Superior temporal. Okay? Cystitis, inferior nasal, adenitis, superior temporal. Okay? All right, so a lot of times these patients are going to have pain and swelling in the area that's being injured, okay? So if there's superior temporal swelling, we're thinking dacryoadenitis. Okay, a lot of times this is idiopathic, okay, but it can be from bacteria. Most often though, we're just going to treat it as bacterial and put an antibiotic on here, and hopefully that clears up. If there is a bacterial infection, it'll clear it up, or if there's just some bacterial overload that the immune system's going crazy, that'll clear that up too. Because once the bacterial overload's taken care of, then the body's immune system will kind of calm down. You will want to do a workup with these, okay? And again, we teach you to what PANCE wants, but if you have an eye care provider right next door, punt, 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 punt. Don't be afraid to punt, okay? I'm not afraid to punt. I punt a lot. Okay. All right. So treatment again, typically is going to start with systemic antibiotics, oral antibiotics, very similar to dacryocystitis. Could do oral steroids if the antibiotic is not working. So within the first couple days, if it's getting worse or if it's unchanged, switch over to oral steroids, right? But a lot of times, again, we're starting with Keflex or augmentin. Okay, dacryoadenitis or chalazion. How would you differentiate between dacryoadenitis and chalazion? Pain, yeah, I would agree. Chalazion is not painful. Dacryoadenitis is going to have some level of pain. Okay, very good. Another picture. All right, newly added to the PANCE 2025 blueprint was dacryostenosis. Okay, again, dacryo means lacrimal. Stenosis means nothing's flowing. Okay, so dacryostenosis, there's a blockage in the lacrimal duct. Nasolacrimal duct obstruction, NLDO. Okay, so again, below the lacrimal sac, sac's right here, and then you got this little duct, right? And that duct then flows into the nose. That's why when you cry, after you fail a test, your nose starts running. I'm sure none of you have experienced that because you're all A+ students. Okay. One of the signs for this is tearing. That should make sense, right? If the tear duct is blocked, then the tears are just going to overflow outside of the eye. There's no place for them to drain, so they stream down the cheek. So a lot of times you'll have parents coming in, because this happens typically in children. You'll have parents coming in complaining that their kid's crying all the time. But there's other things you're going to want to do when a parent says their kid's crying all the time. You want to make sure that the parent's not beating their kid. That's probably the most important. But you could consider dacryostenosis as a differential diagnosis there, because the nasolacrimal duct is obstructed. Okay. So most of the time, dacryl stenosis is congenital, okay? Because as an infant is growing, when they're born, a lot of times that nasolacrimal duct is still closed, especially if you have a preemie, okay? That nasolacrimal duct is still closed. It actually opens up throughout the first year of the patient's life in about 96% of those cases. It will just open up. As that skull grows, that duct will start to open up spontaneously. If it doesn't, then you're going to punt to ophthalmology, and they're going to do one of the most gruesome surgeries that we have. They're going to go in and just like ice pick through that nasolacrimal duct to open it up. It's pretty intense, not super nice to watch or to have done, especially because they're doing it on like a 1-year-old. So, pretty hard to do. But that's dacryl stenosis. Okay. All right, we're going to hit dry eye, keratoconjunctivitis sicca. Out of all the conditions that I have told you, this is probably the one that you will see the most, dry eye. Because I would dare to bet every single person in here has some level of dry eye. Okay? So again, brief review, 3 layers to the tear film, the oily outer layer, middle aqueous layer, okay, and then that inner mucus layer. Mucus layer keeps the tears on the eye, aqueous layer hydrates the eye, oily layer keeps the tears from evaporating. That oil is produced in the meibomian glands, okay? And we already talked about if the meibomian glands become blocked, unable to secrete that meibum, you're going to have dry eye. We call that aqueous deficient dry eye, okay? One of the best ways to treat aqueous deficient dry eye, evaporative dry eye, scratch that. Evaporative dry eye is when the meibomian glands are clogged. One of the best ways to open those meibomian glands up is with this guy right here. This is a Bruder mask. Bruder mask. This is a spa for your eyeballs. One of the most relaxing things that we have, probably the most relaxing thing that we have in our eye care treatment arsenal is a Bruder mask. Okay, you take this mask, you put it in the microwave for about 20 seconds. It heats up nicely. There's some synthetic beads in the mask that retain heat. And you put that sucker on. And then I tell patients to wear it for about 10 minutes. That's usually enough time to heat up the oil in the meibomian glands. And then take it off and kind of milk those glands, for lack of a better term. You're squeezing that meibum out manually. But when I wear it, the Bruder mask, I will usually wake up like 3 hours later because it puts me to sleep almost instantly. It is super duper relaxing. Feels real good. Then I have to do it again because it's cold, right? The meibomian glands need to be heated up so that oil heats up and becomes more liquid, and then you can squeeze it out. You guys probably won't have Bruder masks in your clinic. A lot of times optometry will have them, and patients will come in asking for new Bruder masks. You can also purchase Bruder masks online. I wish I was sponsored by them, but I am not. But I'm a big fan. What you will be prescribing very often is artificial tears. Okay? Refresh Plus is probably the most common. Sustain is another very common artificial tear. Now these are just to be used to support the eyes. Okay? So if you're not producing enough tears, or if you wake up in the morning, you've got really dry eyes, put a drop of the artificial tears in to kind of jumpstart the lacrimal system. And a lot of times patients tolerate that very well. Okay? You'll be putting refills in for artificial tears a lot. Almost everybody is prescribed those. All right. We'll talk about some carcinomas of the lid because that's important to know. Okay, so any skin cancer on the eyelid is carcinoma. Basal and squamous cell are the most common forms of carcinoma on the lid. If you see a patient coming into your clinic for like a sprained ankle, but you notice a weird growth on their eye, okay, don't ignore that, because it could be cancer. At least ask your patients how long they've had that. Some of them will be like, my whole life, unchanged, good to go, case closed, don't worry about it. Some will be like, oh, I didn't even know. And then you're really like, okay, we need to probably refer you to an oncologist to maybe see if that's cancer, because it could be, okay? All right, patients that don't wear sunglasses outside, patients that are very fair-skinned, okay? Elderly patients, they're all much more prone to basal and squamous cell carcinoma. Okay? A lot of times it'll happen on the lower lid, because that's just where the sun will hit. Okay? Fairly common. Always due, not always, but due generally to excessive UV light exposure. Okay, a couple different types of basal cell carcinoma. We've got nodular ulcerative, regular nodular, okay? This nodular ulcerative, say that 10 times fast. We'll have those shiny, firm, pearly nodules, okay? Maybe a rodent ulcer. These are all words that if they're put together in that way, mean basal cell carcinoma. Okay? Shiny, firm, pearly nodule. Rodent ulcer. Probably can stop reading basal cell carcinoma. Okay, then you got squamous cell. It's less common, more aggressive. Right? Same patient type. Excessive UV exposure. Okay. Here's a picture of nodular and ulcerating. Okay. With squamous cell and basal cell. Basal cell is more common. Okay. Basal cell also has the telangiectasia associated with it. Squamous cell does not. So if you want to differentiate the two, pretty similar. One's going to have telangiectasia, basal cell. The other, squamous cell, is not. Okay. All right. Here's some miscellaneous eye conditions. Trichiasis, multiple rows of eyelashes. Not beneficial, okay, unless you're an eyelash model. Even then, probably not beneficial. Floppy eyelid syndrome, okay, kind of a funny name. It's pretty suggestive though. Basically the lid just flops all over the place. Different from ectropion in that the lid's just constantly malpositioned. Floppy eyelid just sort of flops all over the place, caused by some medications. Molluscum contagiosum, not a Harry Potter spell, but a condition caused by HPV, pretty common in kids. My twin 8-year-old boys, they both had molluscum. It was pretty annoying because they had white bumps all over their legs. Pretty contagious, but they got over it because their immune system kicked in. Blepharospasm, okay, is a facial spasm, okay, not a lid twitch. I'm sure you guys get lid twitches in here right now. You're stressed, you're always drinking caffeine, you don't sleep, okay? That'll cause a lid twitch. That is called myokymia, okay? Blepharospasm is actual hemifacial spasm where the whole facial nerve just contracts everything, okay? That's actual blepharospasm. Herpes simplex zoster we'll talk about in the cornea lecture, and we'll talk about preseptal orbital cellulitis in a future lecture as well. Trichiasis, floppy eyelid syndrome, that thing's flopping. Herpes, respecting that midline there. Okay, still respecting the midline. When we get to retina or one of the other lectures, I'll tell you a story about Jordan McGrath. He's an ophthalmologist. I had an interesting run-in with him. Any questions? Sweet. Very good. Let's take 10, and then we'll start back up on conjunctival disorder. Clarify on the keratoconjunctivitis sicca slide. There were this question about topical cyclosporin, which is stasis. That is an immunomodulator that will give to patients who have really dry eyes to try and beef up the lacrimal gland to produce more tears. You guys won't prescribe that. That's either optometry, ophthalmology, or rheumatology. And then there's a picture of scleral lenses on the bottom of that page as well. And a scleral lens is essentially a hard contact lens. It's a solid piece of plastic, and it's large. It actually bolts over the cornea and sits on the sclera. We fill the bowl of that contact lens up with saline, and then the patient puts that on, and then their eye is constantly being hydrated by that saline in that contact lens bowl. Optometry prescribes scleral contact lenses. Most optometrists prescribe scleral contacts. So just wanted to clear that up. Main dry eye treatments for y'all are going to be the artificial tears that you can prescribe, refill, whatever you need to do, and then recommend the dry warm compresses, the burger masks, or whatever other dry warm compress. You can use like uncooked rice, put that in a clean sock, and throw that in a microwave as well. It does essentially the same thing. So there's that. All right, on to conjunctival disorders. We're going to talk about several types of conjunctivitis, okay, and then we'll talk more about some neoplasms. 3 main types of conjunctivitis that I would like you all to know and know how to differentiate and treat, okay? Then we'll talk about subconjunctival hemorrhage. This is the one where your patients are going to be freaking out, but it's really nothing bad, just like a bruise. Pinguiculus with tenules, melanoma, and condylac. Okay, brief review again. Got the bulbar conj that sits over the eyeball itself. Palpebral conj is over the eyelids on the inner portion, and then where they come to meet is the fornix. Okay. All right, another fun picture here. Okay, first type of conjunctivitis that we're going to talk about is viral conjunctivitis. You will see this a lot. Again, especially if you're at an AIT base. Okay? Very, very contagious, right? How do you get viral conjunctivitis? That's the way, yeah, good. Nobody wants to say farting on a pillow. You probably could get it that way as well. That is not the most common way to get it. Typically, like you say, it's either your toddler has it and they cough in your face, because that's what kids love to do, or toddler has it, they wipe their face, and then they touch like a doorknob or something, and then you also touch said doorknob, and then rub your eye. Now you've given yourself viral conjunctivitis. Super, super contagious, okay? Very important that patients are washing their hands, and then washing their hands again, and continuing to wash their hands to prevent the spread of viral conjunctivitis. You can see how this would be an issue in AIT land, because you've got a bunch of 18 to 22-year-olds living together who are not very hygienically minded, and they spread it like wildfire. I've had instances, again, I worked at the TMC optometry clinic before I became an instructor, and we had instances where we had to quarantine an entire barracks because there was just hundreds of viral conjunctivitis patients. So not super fun, but it happens. The good news about viral conjunctivitis is that you don't really need to treat it, okay? It's self-limiting, meaning your body's immune system is going to take care of itself. A lot of times you'll get viral conjunctivitis in one eye, okay? And then you will spread it to the other eye because you wipe your tears and then you wipe the other eye. So it'll often present in one eye and then go to the other, and then about 2 weeks later, it's gone. Okay? As fast as you got it, it's gone. A lot of patients are going to come in not necessarily complaining of pain, but maybe irritation. Their eyes will be red, okay? And they'll be watering. That's the main thing to note. The discharge from viral conjunctivitis is a serous discharge, watery with some proteins in it. Okay? This is pink eye. Okay? If you hear the term pink eye, it is referring to viral conjunctivitis, or it should be. Pink eye is used often for not pink eye, but true pink eye is viral conjunctivitis. Okay, so again, the main sign that you're going to want to take note of is the discharge from the patients, in that it's going to be serous, watery discharge. So a lot of times patients will come in and they'll say their eyelids are kind of glued together, and you might be thinking that's like a mucus discharge that's gluing the lids together. That's just not the case. Because that serous discharge is not just water, it's got proteins in, those proteins will stick to each other, and that's why their lids are glued together in the morning. Okay? Most conjunctivitis is viral conjunctivitis. Okay? Bacterial conjunctivitis is much less common. Another differentiator for viral conjunctivitis will be a case history where you're asking the patient, have you been sick recently? Did you have a recent upper respiratory infection? Like, yeah, like 2 weeks ago I was sick. They transmitted that, that viral disorder to their eyes, and now they have viral conjunctivitis. They can also have their preauricular nodes, some glands right in front of your ear, preauricle, and they can be swollen and tender. That is another good sign that a patient has viral conjunctivitis. I had a patient on that last bullet there. I had a patient that I was treating for viral conjunctivitis because they came in and they said, my eyes red and watery, and it looked red and watery. And so I said, here's some artificial tears. You've got viral conjunctivitis, I suspect. Make sure you're washing your hands really well, and should be gone. Your other eye might get it in a couple days, but it should be gone within a couple weeks. If it's not gone in a couple weeks, or if it gets worse, come on back in and we'll continue treatment. So he came back 2 weeks later, his eye looked worse. I was like, oh, this is not viral conjunctivitis. So being the intelligent doc I am, I didn't Google what's wrong with this patient's eye right in front of the patient. I instead went down the hallway and asked one of my colleagues, and he said, ask him if he has chlamydia. And I said, no, I did not, but that's a good call. I probably should do that, because chlamydia presents very similar in nature to viral conjunctivitis. So we ordered, well, first I asked him, was fun questions. Let me tell you, I can't wait to see y'all have to ask a patient about their nightlife. That's a fun talk. He denied, so we ran a chlamydia screen, and it came back positive for chlamydia. And so we just treated his chlamydia. But chlamydia, I say that all to tell you that chlamydia can mimic viral conjunctivitis. So if it doesn't get better in a couple weeks and they come back to you, probably chlamydia. This is a picture of the preauricular nodes. Not a great picture, but they are swollen. Okay, so again, how do you treat it? It's self-limiting, so you don't really have to treat it. The main thing is you're going to want to counsel the patient, if it's an adult, that they need to wash their hands and not touch anything. I won't put many soldiers on quarters if they have viral conjunctivitis. If they come in and they look extremely irresponsible in their mannerisms, I will put them on quarters, because you can't, there are some soldiers and less airmen, but some airmen, maybe some sailors too, that can't wash their hands. So we'll put them on quarters. But most people can function fine throughout the day with viral conjunctivitis. They just need to wash their hands and be very cognizant of what they're touching. Okay. But mainly it's just artificial tears. So if they're going to put a tear in their eye, it's obviously not an antiviral. It's not going to be treating the viral conjunctivitis. It's purely for comfort. If they've got a bunch of irritation, foreign body sensation from the viral conjunctivitis, just put a tear in every so often to try and moisturize the eye, get some of the crud out. They have to be very mindful, because before they put the tear in, they need to wash their hands really well. After they put the tears in, they need to wash their hands really well. They need to make sure they're not transmitting the viral load onto the actual artificial tear bottle, or they're just going to continually give themselves viral conjunctivitis. So again, if you have a not super responsible patient, maybe don't prescribe anything for them. Some patients just want something prescribed to them. This is a lot of times parents, because their kid has viral conjunctivitis and their kid's keeping them up all night. The parents are really cranky. I can sympathize. I had, my boys had, what is the condition that infants get? Colic, thank you. Man, that was a brain fart. My boys had colic, and I went to the pediatrician. I'm like, please give me something. I need to sleep. Some parents will be just like that with viral conjunctivitis, so you prescribe them artificial tears, giving you this medicated drop. It's not, you just tell them you're prescribing them something to calm them down. Please don't prescribe topical antibiotics for a viral condition. Okay? They get prescribed all the time. I get patients that come in, usually it's kids, because pediatricians will just prescribe polytrim to kids all the time for viral conjunctivitis. It's not needed. Feedstocks, probably no, but they also just want to do something for the parents to put their mind at ease. It's not hurting the kid at all to give them polytrim or a topical antibiotic. It's just not doing anything for the eye condition too. So not the worst thing to give, but you don't have to give that at all. Artificial tears work just fine. Okay, this is a picture of kind of what the eye looks like. If you have viral conjunctivitis, it's pink. Kind of seriously discharge, there's some bumps on there. Might have some corneal changes, called those subepithelial infiltrates, maybe a pseudomembrane, maybe, but I wouldn't worry about that. Any questions on viral conjunctivitis? Wash your hands, artificial tears, serous discharge, preauricular nodes, one eye to the other, self-limited.
One of our professors said that they generally give the antibiotics to the kids just because they're probably going to get hurt bacterial infection because they're messing with their eyes because of your kid already.
Possibly.
Just to eliminate that risk of them coming back.
Yeah. Yes, if you wanted to argue as to giving a kid a topical antibiotic, you could for that reason. They probably are more doing it because the parents are hounding them for some sort of treatment, and you don't want to just tell the parents there's nothing I can do, right? I would rather you just prescribe artificial tears, eye drop. You can just call them, I'm prescribing these eye drops, take them a couple times a day. Most parents aren't going to know the difference between an antibiotic or an artificial tear. So, yeah, you're not right to prescribe a topical antibiotic for a viral disorder, but as long as they're using it to completion, you're also not necessarily wrong per se. So you can make the argument either way, except for the test. Next, we're going to talk about bacterial conjunctivitis. Okay, so bacterial again is much less common than viral conjunctivitis, and it's obviously caused by bacteria. Okay, so this you will use a topical antibiotic to treat. And the main way that you can differentiate this from viral conjunctivitis is the discharge. Right? What did that say about ASAP? If you have any of the chlamydia trachomatis, that would be the trachoma. If you have bacterial conjunctivitis, probably just want to pump that. Like if there's a gross mucousy eye that comes into your clinic, I would pump that to optometry or ophthalmology. Unless you don't have them, then you could treat it with a topical antibiotic. But if you have easy access to eye care, just pump. Okay, beefy red eye and mucopurulent discharge. Okay, this is one of two places that you're going to see that word. The other was with dacryocystitis. Okay, so if you see mucopurulent discharge and there's no bump inferior nasally, and it's probably bacterial conjunctivitis. Okay. This is mucopurulent discharge down here, pretty gross, right? Gonorrhea in the eye is one of the most repulsive looking eyeballs. That is hyperacute mucopurulent discharge. Absolutely disgusting. Gonorrhea, chlamydia, other STDs get into the eye typically by poor hand hygiene. Okay, so touching downstairs and then not washing your hands and then rubbing your eyes. Okay. All right, Vigamox. That is my go-to topical antibiotic, moxifloxacin. Okay. Polytrim is also pretty common. If you see medications, topical ophthalmic medications, they're usually color-coded. So if you have a bottle that's got either a tan cap or like this tan strip on it, it's an antibiotic. And remember, to antibiotics. Okay? It's just a little fun aside for you. All ophthalmic medications have some color code to them. And you can do a workup, like you can try and figure out what's gram positive or gram negative if you really are nerdy like that, or you could just throw on topical antibiotic, which is 10 out of 10 times what I do if I have a mucopurulent discharge coming in. Okay. Topical. You don't need an oral antibiotic for these because it's a surface disorder, and the conjunctiva is on the surface. So topical antibiotics work just fine for that. Okay. If it's real bad, and you suspect like chlamydia or gonorrhea or anything like that, perhaps ophthalmology or the ER will give an IM shot, but oftentimes topical antibiotics work just fine for this. Okay. All right. Pretty gross. Yep, that's pretty gross. Those lashes are all matted together. Okay, that's a lot of mucus. That is a mucopurulent discharge. Here's chlamydia in the eye. Okay, you can see how that could be mistaken for viral conjunctivitis, right? If you're looking at that, nothing really says, I'm chlamydia. So that's why it's often mistaken. Or chlamydia. Gonorrhea, look how nasty that is. That is so much discharge right there. Okay, that will happen very quickly too. It is hyperacute, the discharge with gonorrhea in the eye, conjunctivitis. Okay, it comes right away. Okay, tons of discharge with gonococcal conjunctivitis. Very gross. Punt this. Okay, that comes into your clinic. All right. Viral, serous discharge. Bacterial, mucopurulent discharge. Viral, self-limiting, maybe an artificial tear. Bacterial, topical, antibiotic. Now we've got allergic conjunctivitis. Also pretty common, especially here in Texas, especially in January and March, when oak and mountain cedar are pollinating respectively. Terrible, absolutely terrible. I am very susceptible to Texan allergies. I hate them. I love Texas, but I hate the allergies here. And my eyes start to itch, so like nasally. That's typically where the itch happens, right on the nasal caruncle. And you'll just want to dig your finger into your eye and rub the crap out of it. It feels so good. Then you give yourself keratoconus, and you'll need a corneal transplant because you rub too hard. So instead, what we like to do before a patient gives himself keratoconus is prescribe a topical antihistamine, which are phenomenal. They take the itch away right away. We'll also prescribe like Zyrtec or Claritin, and you guys will be prescribing that like candy as well. Okay. But the main symptom, or the main thing to remember with allergic conjunctivitis, is it's going to be bilateral. The allergy is affecting the whole body. Okay, so it's not just going to be one eye or the other. It's going to be both eyes. And itch is the main thing to remember. Okay. I don't really care about a discharge with allergic conjunctivitis. You know, it says like a ropey discharge. That's fine. But itch is the main thing. Does the patient have eye itch? Then it's probably allergic conjunctivitis. You'll note that it's just a cat up here. Dogs are fine. Dogs are better than cats. Cat people in here?
Hell yeah.
You gotta have it. All right. You failed. Failure. Okay, intense itching, right? There may be some other signs, but a lot of times the patient comes in and they're all stuffed up. They know they've got allergies. Their eyes are itching. They've got allergic conjunctivitis. Okay, it's a pretty easy diagnosis there. How do we treat it? Try to get rid of the inciting agent. So hunt that cat, okay? Or leave Texas. That's hard to do if you are stationed here. So what we can do instead is perhaps prescribe artificial tears. Probably not, though. That's not going to do anything. Patients coming to you complaining that their eyes are itching, please don't just prescribe an artificial tear, because that's not going to do anything for their eye itch. Rather, you should prescribe a topical antihistamine. Now, there's only one on the formulary, and it's Patanol. Don't prescribe that. Instead, and you can write this down, tell your patients to go get Pataday once daily extra strength. That is the best eye drop out there for the treatment of ocular allergic conjunctivitis. It works super fast, and it's a 24-hour drop. So it's just one drop in the morning, and you're good to go. Pataday once daily extra strength. That's my favorite. That's the one I've tried many, and that's the one that works the best. Topical steroids are an option if you have a patient with severe allergic conjunctivitis, like the Pataday is just not doing anything, the Zyrtec's not helping at all, their eyes still itch like crazy. Topical steroid would be the next thing that we would prescribe, but again, that's going to be me or ophthalmology, okay? So don't prescribe a topical steroid for allergic conjunctivitis in the real world or for the test. You can get some big bumps underneath the eye if you have severe allergic reactions as well. We call this papilla, okay? Just kind of what the underside, that's a picture of the palpebral conj if the upper lid is flipped up, inverted. Any questions on conjunctivitis? Hopefully I've broken it down so you can differentiate the 3 different types. And that's all that you really need to know about it. All right, now we're going to talk about a subconjunctival hemorrhage. Okay, patients are going to be freaking out. Hey, doctor, woke up this morning, my eye's bleeding. That sounds intense. Let's figure out where the bleed is. Is it over the colored part of your eye, or is it over the white part of your eye? Oh, it's over the white part of my eye. Okay. Is the blood tearing down your face, or is it just kind of staying stationary on the eye? Well, it's just kind of staying stationary over the white part of my eye. Okay. I'm not going to diagnose the subconjunctiva on the phone, but that's what they have, right? You can ask them, have they been coughing a lot recently? Do they have a bleeding disorder? Are they on any anticoagulants, baby aspirin? They get hit, okay? Those are all things to get a subconjunctiva. Everybody knows what Valsalva is? Okay, good. Were you constipated recently? Okay, that's a good question to ask. Perhaps they're pushing pretty hard, popping a blood vessel. This is just a bruise under the eye, okay? That's what a subconjunctiva is, just a bruise under the eye. This is what a bruise would look like if your skin was clear. Okay, fortunately, it's not. If they have one subconjunctiva, I don't care. It's going to go away just like a bruise does. There's no treatment for it. Nothing really that we have to do other than provide reassurance to the patient. Okay. If they have a history of subconjunctivitis and they don't have a bleeding disorder, now we're going to start running like blood panels to see if they've got any sort of bleeding disorder or any other disease that's causing excessive bleeding. Ask about their medications, okay, trauma, that type of thing. But really, this is one of the most unnerving conditions that a patient's going to get. And it's also kind of unnerving because there's nothing that we can really do to treat it. It's just going to go away on its own in a couple weeks, but just providing that patient reassurance that this too shall pass. This is just like a bruise. If you explain it like that, most patients will understand just fine. Okay. This is the workup you're going to do. Again, treatment, you don't really do any treatment for this unless they're on blood thinners. Then you're probably going to want to consult, or as PAs, if you're the one that's prescribing the blood thinner, you may want to figure something else out. But that's on you. Okay. That's why you can pay the big bucks. All right, here's a picture of subcon sheen. This is a picture of subcon sheen. I took this picture. This is one of my patients. On my 4th year in optometry school, this guy came in to my externship site, and he's like, "Hey, woke up like this." I'm like, "Did you? Are you in any pain?" "No." "My eyes red though." I was like, "Yeah, I agree." This was so red, there was so much blood in there. You can see that lower lid is actually popping away from the eye there. And really, we just did a full exam on him, got him dilated, make sure there's nothing else wrong with the eye, and then diagnosed him with a subcon sheen, and I never saw the man again. He was a rancher in Arizona, and I'm sure he didn't want to come to the doc. His wife probably made him come in, but wasn't anything to do about it, so we just let him go on his way. Just a bruise. That's a big bruise, though. Okay, next we're going to talk about a pinguecula. Pinguecula is a raised yellowish white lesion on the conjunctiva, okay? Kind of like a callus. You can think of a pinguecula like a callus. So patients that don't wear sunglasses, hopefully by the end of this you understand sunglasses are important. Patients that don't wear sunglasses, they're in dry, dusty environments, are more susceptible to pinguecula. Okay? And again, it's just kind of like a callus over the conjunctiva. So as that air and dust blows on it, on the conj, just like you get calluses on your hands, you can get a callus on your conj. And that's called a pinguecula. Okay? They may be irritated, but a lot of times these patients are going to be asymptomatic. If it's real big and real yellow, the patients, and it comes out of nowhere, the patients are going to be maybe a little more noticeable about it. Or if you're doing an exam on a patient and you can notice it with the naked eye, you might ask about it as well. Oftentimes these go undiagnosed, and it's okay because they're benign lesions. They don't really turn into anything, not cancerous at all. They may become inflamed though, and that's when the patients might come in to see you. But ordinarily these are painless, okay? And you can just see the little yellowish white lesion, the raised lesion right here, okay? You can see the blood vessels underneath that become hard to see right here. That's because that lesion is overtaking them. That's a pinguecula. Okay, we'll treat with artificial tears. They don't really go away. And they don't really bother patients. So typically, these are very low on the list of things that we care about, but just for diagnosis' sake. If it is inflamed, we'll put a topical steroid on it. So punt them over to optometry or ophthalmology, we'll give them a steroid for it, just to reduce that inflammation. But the pinguecula is going to stay there forever. Okay, next is a flictennial. These are not super common. This is a staph hypersensitivity. Okay, and you'll get this little lesion right at the limbus. Okay, the limbus is where the cornea and sclera come to meet. So staph hypersensitivity there is called a flictennial. And that's really all I want you to know about that. Next, we're going to talk about a conjunctival nevus. Okay? Sometimes you can have pigment on the conjunctiva that's not blood. And it can either be a nevus or it can be what's called racial melanosis. If you've got more melanin in your skin, sometimes that melanin will protrude onto the cornea and cause like a little freckle there. It can also turn into a nevus as well. Obviously, nevus is non-cancerous, but if a patient does have some sort of conjunctivus, then we are going to monitor that for any changes. So you want to make sure you're asking the patients a good case history. How long have you had that? One thing you can do with eyelid and eye disorders is ask them to pull out like a driver's license if they have, or an old ID. And if they have that picture in like or if they have that growth in something that's like 10 years old and it's unchanged, that's usually a good sign. If they don't, then perhaps that needs further investigation. We're not going to really do anything with a conjunctivus until it changes and potentially becomes melanoma, but hopefully it does not. These are some gnarly nevuses. They look pretty bad. Still just a nevus. Nevus. This is bad though. Okay, conjumelanoma, that's something you don't want to get. What do we notice with some of these melanomas? Yeah, raised and yeah, they got that feeder vessel, big feeder coming to it. Okay, so you can't really appreciate much of a feeder. It's probably off to the side here, but this feeder right there. Okay, a typical nevus won't have that, but the melanoma does. And like any other type of melanoma, potentially deadly. We need to get this patient treated and examined. This is a worse picture of melanoma here, right? Hopefully this is something that has just happened on this patient and not something that the patient's had for 2 years but refused to come in and get seen. You can even see like the blackness on the lash line there. So even if the patient's not pulling down their eyelid to inspect under there, they can still see like, hey, my lid's black in that one spot. Maybe I should go to the eye doctor. A lot of patients won't, unfortunately. Okay. You refer melanomas, by the way. Not to me. I'm not doing anything with it. Ophthalmology. Okay, conj lacerations. So you can have a laceration on the conj. Okay. If the conjunctiva is lacerated, our biggest concern is that the globe has been ruptured, which is a bad thing. We don't want an open globe, okay? Because then you can get bacteria inside of the eye, you can get endophthalmitis, and then you can lose the eye. So if you have a conj laceration and you're stateside here, hunt it, okay? If you're not, and let's say you're overseas, you want to do a little more investigating, okay? Do your full eye exam, stain them up with fluorescein, use your Woods lamp to appreciate the actual laceration. You can check for like a Seidel sign, which would be that fluid coming out of the eye. CT scan, good case history. And then if it's just a conj laceration and you are the only provider in 200 miles, okay, and we're in a LISCO situation where we can't medevac this patient out. If it's a tiny one, just put some ointment on it and that conj will heal itself. If it's a big one, over 1 centimeter, you can suture it closed, okay? Probably gonna try to refer this to ophthalmology because suturing on the eyeball is pretty difficult, especially on the conj, which is like millimeter max thick, probably 500 microns thick. That's gonna be pretty difficult to do. The other thing, and it's not on here, if you're just stabilizing a patient, they don't have an open globe injury, it's just a conj laceration, the other thing you can do is the erythromycin ointment and put a Fox shield on, the rigid eye shield, and then ship them that way so no further damage happens to that eye. A lot of times that's what the treatment modality is going to be operationally, is Fox shield over the damaged eye, and then get them stabilized and shipped back to a higher role of care. Okay, this is what the conj laceration is going to look like under the fluorescein stain. So there's a laceration here, and that fluorescein stain is embedding into the underlying episclera and sclera. Okay, it's soaking in there. It's not soaking into the conj. Okay, so that's the laceration under fluorescein stain, and then here you can see it unstained there. That's a pretty big laceration. So really, you throw some erythromycin ointment on there. Don't pressure patch this. Never pressure patch that. Probably never pressure patch anything in your careers, because pressure patching generally is not a good thing to do. It's taught a lot. And it's a task that my soldiers need to do, and I tell them never to do it. Because if you pressure patch a conj lac, and you have an open globe, well, now you've squeezed all the contents of the globe out of the globe, which is not good. So don't pressure patch. Instead, use a Fox shield. Okay? Erythromycin ointment and a Fox shield is a perfectly acceptable treatment for these patients overseas, so they can get to ophthalmology. All right, let's talk briefly about thyroid eye disease. It's kind of a weird spot to have it, but there's no real good place to put thyroid eye disease. This is obviously a thyroid condition that affects the eyes, where the EOMs will become swollen, the extraocular muscles will become swollen and more rigid, and this is going to cause the eye to protrude out of the eye, proptosis, something else. For eye care folks with thyroid eye disease, we're trying to treat the dry eye. For primary care docs, you guys are going to be focused more on the thyroid. Fix the thyroid condition, and then the eyes will go back to normal. You can also prescribe eye drops. Keep that in mind if you have a patient that's got thyroid disorder. Their eyes might be a little jacked up. They probably have ophthalmos here because those eyes are protruding quite a bit. If you notice this patient kind of get that weird bug eye appearance to it, that's called scleral show. You shouldn't be able to see the superior and inferior sclera normally. Okay, so if you look to your left, look to your right. None of you should have your scleras showing superiorly and inferiorly. Your lid should be covering those areas. If they are, it doesn't mean you have thyroid eye disease, but that's not technically normal. Okay. All right. So again, when we think of thyroid eye disease, we're not necessarily trying to treat the thyroid condition. I'm definitely not. I'm just treating the dry eye symptoms that the patient's going to have. So we're going to prescribe artificial tears, maybe lid taping. Again, patients hate that. Moisture chamber goggles if they can't close the eyes. Maybe scleral lens if we can't fix the thyroid condition. Okay. So I'm definitely making sure after this patient sees me that they go see y'all so you can work on that thyroid. Okay. Gradual onset with thyroid eye disease. Again, you get that lid retraction and leg ophthalmos. Bunch of puffiness around the orbit there. Might also be concerned, like if I initially see this patient, I'm more concerned for orbital cellulitis instead of thyroid eye disease, but she's got puffiness from overactive thyroid, or underactive, I suppose. This is called conjunctivosis right here. You can see how that conjunctiva is swollen right there. That's not normal. Okay, it should be like this conj here, sitting flat and mostly quiet. This is all injected and swollen. That's not normal. Okay. For this side of the room, chemosis right there. Swollen conjunctiva is called chemosis. MRI for you guys to note a swollen medial rectus pushing everything forward. Swollen medial rectus, swollen inferior rectus. Okay, what are we going to do? Again, can tape the lids. Patients hate that. So mostly flooding the eyes with artificial tears and trying to get the thyroid under control. All right. Any questions on the conjunctival disorders? So let me run through the Morgan lens lecture here real quick. Give you a quick taste of Friday morning. This is on your Canvas slides. You can go back and look at it if you want, but you don't have to. All right. If a patient gets a chemical in their eyes, we need to irrigate their eyes. The easiest way to irrigate a patient for you as the provider is going to be with a Morgan lens. Because all you have to do is get that lens in the eye and it's hooked up to a bag of saline, and you just walk away from the patient. It's constantly going to be irrigating that eye. If you don't have, a Morgan lens, then you have to stand over that patient and spray either saline or a bottle of something, water, I don't really care, over the patient's eyes for 30 minutes. That gets very tiring after like 1 minute, okay? So 30 minutes is what we need for ocular irrigation. The Morgan lens is a great way to do that because it's hands-off. Super, super simple. You guys are going to be doing it to each other, sorry, in advance. It's not the most enjoyable thing, okay? But it's also not terrible. We'll give you some numbing drops so you won't feel anything. It's going to be uncomfortable because you guys got to get up and close to the eyes. But it's not bad. We only have one faint. I'm just kidding. Nobody's ever fainted. It's always gone fine. So whoever's the patient, you'll kind of team up. The patient will get a drop of proparacaine in the eye that they're going to get the Morgan lens into. Proparacaine numbs your eyes, lasts for about 20 minutes, and one drop starts working within a matter of seconds. So your eye will feel numb. The lid, when you get the proparacaine in, is going to feel heavy. Okay? So when your lid starts to feel weird, the proparacaine is working. Your eye is numb. Whoever is administering the Morgan lens then will attach the lens. Let's see if we have pictures here. All right. This is the lens itself. Okay, it's attached to a tubing. You're going to connect that tube up to the bag of saline and the flow regulator. And once it's all connected, you're going to start your flow a little bit. It just needs to be dripping. And don't think you need to memorize this. We'll tell you again right before you do this. Once it's dripping, then you pull down the lower lid. Okay, put the Morgan lens in, let that down. You pull the upper lid up, put it in the upper lid, and you're good to go. Okay. I have 4 or 5 instructors that are going to be teaching you guys how to do this in the eye lanes in MIT 5, and they all do it mostly the same way. They may do upper lid first, then lower lid. Doesn't really matter how you do it. As long as you get it underneath both eyelids, seated on the eye, and let the patient's eyelids go, and the Morgan lens is just on the patient's eye. And they've got like a tube coming out of their eye. Then you increase the flow, it starts to really irrigate the patient. Okay, and it's the beauty of the Morgan lens, again, is it's hands-off for you. And once you've got it in, you're good to go. You can let them irrigate for half an hour, and then you'll take the Morgan lens out after 30 minutes. And we let the eye kind of get its natural pH after that, so we'll wait about 5 to 10 minutes after you take the lens out. And then you're going to use a pH strip to check the pH to make sure everything's neutral. If it's not neutral, then you do 30 more minutes, and you wait 5 to 10 to check the pH until it's neutral. Okay? If we don't get a patient's eye irrigated, the acid or the base, whatever's in there, is going to scar the cornea. When that cornea scars, that patient is essentially legally blind for the rest of their life, unless they're able to get a corneal transplant. Okay? So we want to prevent that as much as possible. So this is a true ocular emergency, any sort of chemical injury to the eye. This needs to get irrigated right away. Okay? Don't take a case history, don't check VAs, don't do anything. If a patient comes in saying, I got something in my eye, start irrigating their eye. Okay? You're not going to do any damage to them if you start irrigating right away. Copious irrigation. All right. Here is MIF 5. This is the Med COE right here. You can walk down William Hardy Road, come in this parking lot right here, some dumpsters right here, walk up to the front door of MIF 5. Okay, go through the front doors of MIF 5. You're going to turn to the right. Then you're going to see a staircase. You're going to go downstairs. Then you're going to turn right again. And then there'll be signs. We'll have signs up too. Talk to your class lead. We're going to split y'all up into 4 groups. Okay? So the lab goes from 8 to 11 You're not gonna be there from 8 to 11. We'll have one group there at 8, and usually every like 45 minutes after, you guys come in waves. So you're gonna do Morgan lens on each other, and then you'll have a slit lamp tutorial, where you'll get the basics of the slit lamp, and you guys can kind of play with the slit lamp as well, and then you'll be free to go. Okay. And then I lecture again Wednesday afternoon. So you get a lot of me on Wednesday and Thursday. I've got 2 lectures too. Any questions on the Morgan lens? Yeah, please. PT is perfectly fine. And then anybody in contact lenses? Don't wear your contacts. Yeah. Okay. For lecture Wednesday afternoon, I'm gonna do my best to get through lectures 5, 6, and 7. Okay, they're kind of shorter, and it's doable. I've done it in the past. It works out well. And then we can have all of lecture 8 for just one 2-hour block. It works out better that way because lecture 8 is a lot. That's the retina. There's a lot of retinal conditions. All right. Any questions for me? Sweet. See you Wednesday morning.